Cool.
Wonderful. Okay, well, everyone, first of all, let me apologize for that little delay in getting us started for tonight's edition of the AMSSM National Fellows Online Lecture Series. I'm Julie Creech. I'll be your moderator for tonight's lecture, which is going to be given by Karl B. Fields, and he's going to talk to us about overuse injury of the lateral and the posterior knee. Before I go more into his introduction, let me just kind of go over the basic ground rules for our series today. So this is brought to you by the Fellows Education Subcommittee, the AMSSM Education Committee, as well as the Fellowship Committee. The goals of tonight's lecture, as well as all the lectures in the series, are just to serve as an adjunct to your individual program's educational programming, provide the fellows with direct access to educational experiences that are provided by experienced AMSS members and sometimes some of our expert invited guests in a variety of formats, and also to assist with your CAQ preparation. Throughout the course of tonight's lecture, we ask that you mute your device's microphone and turn off your video. If you have any questions that arise throughout the lecture, please feel free to submit those through the chat function, either for the whole, all the attendees to see, or you can submit them directly to me. And if you want to include your program and your personal name, please feel free to do that. I'll then ask the questions at the end of the presentation, and we'll have a live Q&A. And then at the very end in the comment section, you will see a link for the post lecture evaluation, just so we can gather information on the lecture series and help better tailor to your guys' future needs. So without further ado, let me introduce our speaker for this evening, Karl B. Fields. Karl Fields is the founder and emeritus director of the Cone Health System Sports Medicine Fellowship in Greensboro, North Carolina. He is director of undergraduate medical education for Greensboro AHEC. He's a professor for the Department of Family Medicine at the University of North Carolina at Chapel Hill, and a member of the Board of Visitors for the School of Health and Human Services at the University of North Carolina at Greensboro. Dr. Fields is a board-certified physician in family medicine and holds a CAQ and ATC Certificate of Added Qualifications in Sports Medicine. Dr. Fields is past president and a charter fellow for the American Medical Society for Sports Medicine. He teaches sports medicine with AMSSM, the American College of Sports Medicine, and the American Academy of Family Physicians. He has been a visiting professor of sports medicine in Australia, England, China, Chile, Italy, South Africa, Qatar, Turkey, and Norway. He's the editor-in-chief for sports medicine in the section for Up to Date. His research focuses on running injuries, orthotics, home rehabilitation interventions, and tendinopathy. He is also active in teaching, curriculum development, and case board research in the musculoskeletal diagnostic ultrasound in sports medicine. He currently directs a diagnostic ultrasound fellowship. He has extensive publications in the field of sports medicine. Dr. Fields has spent many years as a team physician. He has twice provided medical coverage for the U.S. Figure Skating Championships, as well as the Olympic Marathon Trials, U.S. Cross Country Championships, the Marine Corps Marathon, Ironman Triathlon Championships, U.S. Gymnastic Championships, and the American Cup Gymnastics, as well as numerous other sporting events. Dr. Fields was awarded a Bachelor's of Arts in Classical Civilization from Yale University and an MD degree from the University of Kentucky. He completed his family medicine residency at Charlotte Memorial Hospital and an academic fellowship at the University of North Carolina. So without further ado, I'm going to switch it on over and we'll give the screen now to Dr. Fields.
Well, thank you. And I'm looking forward to talking to this group. Thanks for showing up tonight. It's a late hour and I'll try to finish this up in the next 30 minutes or so. So I'm going to talk to you about overuse injuries of the lateral and the posterior knee. And let's see, it probably won't let me advance the slides. If you don't mind advancing the slide for me, please. Next slide. So first, let's do a few goals and objectives. And what I'd like to talk to you about is learn the key overuse injuries that cause lateral and posterior knee pain. Understand the mechanisms of injuries for lateral and posterior knee pain, And then know some key evidence-based medicine for treatment of ITB syndrome. That's certainly going to be the commonest thing you see causing lateral knee pain. Know the key evidence-based medicine for treatment of posterior knee pain that's coming from hamstring injury. Next slide. So this is a picture of the lateral knee, and you can see that it's fairly complex. Coming down, you have your iliotibial band, and just anterior to that, you have your vastus lateralis tendon. Posterior to that, you have your biceps femoris tendon. And what you'll notice is under all these areas, there are bursal areas that can be either true or pseudo bursas, but there are areas where you can look for swelling or injury. And then deep to that would be your popliteal tendon. So next slide. So the key differential diagnosis we have of lateral overuse knee pain is iliotibial band syndrome, popliteal tendinopathy, vastus lateral tendinopathy. And then if we go to the posterior lateral area, we're looking at the biceps femoris tendinopathy and proximal gastrocnemius tendinopathy of the lateral gastrocnemius. Next slide. So starting off with the epidemiology of ITB. This is really a common condition. It's the second most common overuse injury to the knee. And it's the second most common knee injury of runners. And probably if you look at elite runners, ITB is more common than what they call runner's knee, patellofemoral pain syndrome, or other thing. And it affects up to 12% of runners overall. The next most common sport in which we see ITB injury is cycling. And 24% of the knee injuries that we see in cycling are related to the ITB. Usually, however, ITB injury requires a weight-bearing activity, or in cyclists, we tend to see it in higher level cyclists because it requires a very high resistance. So you're essentially weight-bearing when you're in your cycle stroke. It's less common in soccer, skiing, and other recreational sports. It's more common in these two more endurance sports. Next slide. And so we know that the pain is typically felt at Gertie's tubercle, which is the lateral femoral epicondyle. The cause of the pain at one time, certainly when I came up, we would try to manipulate the ITB, and we felt that it was friction, that it was rubbing. But some very sophisticated studies have shown that very little motion occurs around the ITB. It's probably not sliding and giving friction. And it's, I'm sorry, would you go back one slide, please? So it's probably more related to compression of the soft tissues around that area that we're feeling. So when the ITB is too tight, has too much pressure on it for biomechanical reasons or others, you're getting pressure on the soft tissue. Factors that can influence this are varus alignment in running or in cycling, and both of those have been demonstrated to create more pressure at Gertie's tubercle. Supinated foot strike is important and may increase the risk, and that is probably a key reason we see it a little more often in your elite runners, because a lot of them have a supinated foot strike, and a lot of them have a cavus foot, which tends to be quite supinated. Next slide, please.
Dr. Fields, I'm going to pause real quick because it looks like some people are only seeing half of our screen. So I'm going to just reshare so that way, hopefully, we don't have that same problem.
Thank you. Because I was only seeing half of it, honestly.
Okay, you just knew it so well. All right, so let's see. Is everyone, I don't know why that's doing that. That's interesting. Okay, let me do this again. All right, everyone. Are we seeing that better? Can everyone see the full screen now?
I can.
Okay.
So, so this is the slide I just discussed. I'm sorry if you couldn't see that, but what we're thinking is ITB really is probably, the pain pattern is probably generated from compression of soft tissue, maybe even some tissue in the synovial recess. So you get pseudobursal swelling, not always true bursal swelling, because it's unclear whether there's a true bursa right under the ITB. And we talked about supinated foot strike being a factor in this. Next slide, please. So one of the things about ITB syndrome is there's some things we know about how it presents. And one of the ways it presents is that you get a variable sharp pain, and particularly for runners, they see this at different paces at foot strike. So that the pain can be present when you're running along at 7 minutes a mile, you speed up to 6:30 and it goes away. You drop down to 6, it comes back. So you can get variable paces are causing the compression that you get on the ITB. So this is useful for you in trying to talk to your runners about how to train through this if you want to allow them to train while they're trying to deal with it. However, initially the pain can only be with the sport, but if it starts becoming more persistent where it's present all the time, then you probably cannot let them train with it. An older study done by Messier over at Wake Forest showed that pain was aggravated by downhills, aggravated by slope surfaces, and with increased mileage. But the precipitating factor often is difficult to ascertain. A lot of runners say they didn't notice any real change in their training or what they were doing. It just came on at a certain time and started getting worse. Interestingly, non-impact activity does not cause pain. So I'll have a lot of runners who feel pretty severe pain with running. But if I have them bike at medium resistance, if I have them swim, even if I have them use a Stairmaster or elliptical, they really don't get pain with this. So you can cross-train very effectively when you have an athlete who's getting ITB. John Orchard showed in a number of studies that he was doing with ITB, one of the things he was able to show is that when you get this pressure impingement, it's usually just at or below 30 degrees of knee flexion. And it's on the weight-bearing strike or the downstroke in cycling. In fact, the range that he found it at was 28 to 32 degrees of knee flexion. So you can see why certain paces where you're not getting into that knee flexion range very often might be more comfortable than others. Next slide. So generally we perform a general exam as we would at any other time, a full knee exam. I like to see that we always examine the joint above the hip and the ankle below. Look at leg length, because there have been a number of studies which suggested, but none that have proven that leg length inequality was a factor in ITB. Look at alignment. Do they have a lot of varus alignment? I think that's significant. But the opposite may be true as well if you had a lot of extreme valgus alignment. And look at foot stance, because as I mentioned before, it seems that more commonly than a pronated foot, a highly supinated foot would be more likely to cause this. So when it's supinated, it's strike, tightness, pressure being generated down the ITB. When it's a pronated foot strike, it's because you're creating a lot of dynamic genu valgus that's crossing into thigh adduction. So you're actually stretching that ITB, giving it a torque every time you get a foot strike with that. The special tests we use are Overuse test, which checks for tightness, but it's considered, several people have studied the value of this and found it to be limited. Noble's test has had more positive reviews. So basically in Noble's test, I'll show you in just a second, but you're putting pressure on the lateral epicondyle, you're flexing the knee to 90 degrees and extending it and looking at where you feel pain, which will usually be about 30 degrees of flexion. Thomas's test can check for tightness of your quads and hip flexors, and so that also could potentially increase pressure on the ITB. Clinical studies, this is a clinical diagnosis, so we don't necessarily have to do any imaging. I like to use ultrasound for it. And what I'm generally looking for with ultrasound is whether you get any pseudobursal swelling or any increased Doppler flow in around Gertie's tubercle or where the ITB crosses. Next slide, please. So this is a gait analysis observation. The fellow on my right side, as I'm looking at the screen, number 109 is the winner of the race. And he's an elite runner. He's striking in supination, and he's got pressure going up the lateral column of his leg. So that's typical of the position that you see running form of elite runners who would be getting pressure on their ITB. The other two fellows on the opposite screen are just the opposite biomechanical reason that we'll see when we do a gait analysis of getting ITB. You can see the gentleman in black is already in some genu valgus, as is the gentleman in red. They're starting into a little bit of valgus. The fellow in black is already pronated at his foot and is probably going to strike with significant pronation. And there's some early pronation going on in the gentleman in red. So either of those extremes of gait may help you say, is there a biomechanical factor in this? This becomes important because with orthotics and other sorts of exercises things, we can change biomechanics in runners. So I would tell each of you fellows, if you're diagnosing ITB in a runner, you really don't know that you've done a good exam until you've actually seen their gait and see what they do with their gait. Next slide, please. So this is Overuse test and Noble's test. So when he rolls him on his side, he's going to drop the leg down, see how far it comes before he gets tightness. That's your Overuse test. Take it down. All right, when he gets down into the Overuse position and he starts flexing and extending it with his thumb against the lateral Gerdy's tubercle, that's your Noble's test. And if you had pain with that, that would be a positive test. Next slide, please. So 20 years ago, a study came out by Fredrickson and his colleagues out at Stanford that changed my whole approach to treating ITB, and it's been so valuable to me. I really consider this, even though it was a small study, to be somewhat of a landmark study. He looked at 24 consecutive distance runners who had ITB at his running injury clinic. Their average age was 27, and then he got a control group of 30 Stanford runners to compare this group with. Next slide. What they did was a lateral leg lift, which I'm having my model demonstrate in this, to about 30 degrees against a dynamometer until failure. And they practiced this a couple times before doing the final test to see what the strength was. And then he normalized the amount of force that the person could generate with this testing for height and weight. Next slide. So what we found is that this was a key test for the gluteus medius in particular, because it's a continuous abductor in stance phase, and it gets some assistance from the gluteus minimus and the tensor fascia lata. So at foot strike, all three of these muscles are undergoing an eccentric contraction, and they're controlling the actual tension on that ITB. Weakness of the gluteus medius in particular allows you to get in that increased thigh adduction, which can increase the dynamic genu valgus and the stresses on the ITB as well. So this weakness of gluteus medius was the key finding that he found in this study. Next slide. What he found was the injured runners showed a strength deficit, not only against controls, but also against their uninjured leg. And all those values were statistically significant. So with a 6-week program that really emphasized only one exercise, although they did a couple of other adductor exercises, but lateral leg lifts, and you build up to doing 3 sets of 15 lateral leg lifts, starting with a 2-pound weight on your ankle, moving it up to a 3, 4, 5-pound weight. They were able to show significant increase in strength in only 6 weeks, but the clinical outcomes were what were so outstanding. 22 of the 24 runners were pain-free with this exercise at 6 weeks. 1 at 3 months. So 23 of 24 by 3 months had resolved their symptoms of ITB just by doing a simple rehab exercise. So even though this is a small study, I would tell you in my clinical experience working with lots of runners, this has been the most valuable treatment that I've found for ITB. Next slide. So, but I always get that little resistant one. In fact, when I was seeing a lot more elite runners several years ago, I would always leave a couple of work-in spots near the Boston Marathon, near the Marine Corps Marathon, and other big marathon spots, because I was certainly going to have one of my elite runners come in with ITB. And, you know, they're dying to run the marathon. They've done all the preparation. So the question was, would a corticosteroid injection help them? And so our colleagues over in South Africa, Dr. Gunter and Schwalnus, did this nice little study. It's a very small study. They only had 9 people in it. They used a 2 cc injection, 40 milligrams of methylprednisolone and 1 cc of lignocaine. And then they recorded pain regularly, and they repeated a treadmill test on these runners at days 7 and 14. So what they saw was during the first week, there was a trend toward decreased pain. During the second week, they had a statistically significant amount of decreased pain. This too has been my experience and has guided my sort of treatment of iliotibial band over a number of years, in that with this injection, you can usually get them through 2 or 3 weeks of less pain, and it may help someone complete an important race. I doubt that it makes much difference in the overall long-term outcome, but it's a good adjunct so that you can let your runner continue to compete in an important race. Next slide. What do we have no evidence for? PRP or stem cell injections to this area. Just nothing shown up that's been important with that. Dry needling. I hate to say it, but I think dry needling has become more of a fad than a science, because really it was designed for problems in muscles where there was tightness, scar tissue built up, and dry needling really helped that. I saw it when it was first being introduced down in Australia years ago. I saw very successful use of this, but I don't think there's any evidence that it's helped to really try to dry needle the iliotibial band or some of the tissues around there. And a lot of the patients find that painful. I love using nitroglycerin patches for a lot of the tendinopathies I see, but I doubt it does a thing on the ITB, and we do not use it there just because I don't think there's any evidence that it works. Prolotherapy, again, another disappointing sort of treatment that hasn't shown any real benefit in the small studies that looked at ITB. Next slide. So conclusions. If you're doing primary prevention for ITB, stretching makes sense. Strengthening the hip abductors makes a lot of sense, and that's probably the most important thing we're going to do. But you can use conservative management. You want to try to control the pain, the inflammation, increase the range of motion if it's limited at all, increase their strength, modify their activities, and let them have a gradual return to play. I really do look at that gait though, and I'll make a correction if I see a leg length inequality, or if I see that they're pronating excessively. I may try to control that with a sports insole, with a scaphoid pad, or with a custom orthotics. Steroid injections, really just for pain relief in the first few weeks to try to help them get through to a race, or maybe to push the rehab a little hard. Return to play or return to running, I will let a lot of my runners, if they can find a comfortable running pace that doesn't give them pain in their ITB, while they're doing their exercises, while they're rehabbing this, I will let them train through this, but the rule is no limping, or else then they should concentrate on the cross training. Cross training is usually effective to maintain the fitness, and there are several cross training things that will not cause pain with it. But the key treatment strategy is strengthen the hip abduction. And there's a nice review of ITB. It's actually one of the most popular topics in Up to Date by John Jackson, if any of you want to look at that. Next slide, please. So lateral knee, the second tendinopathy to talk about is popliteal tendinopathy. And this is something that you're rarely going to diagnose. We did have a case last week, and I'm sorry that I can't show you my slides because I actually have the ultrasound from that one. But it's an uncommon cause of lateral knee pain. We don't see a lot of it. Popliteal acts as a check rein to keep the knee from translating and to block tibial internal rotation at foot strike. So it's a limited motion that it makes. It's the little small muscle you see going right across the popliteal fossa and inserting just on the lateral aspect of the femoral epicondyle in a little notch. So the injury mechanism for damaging the popliteal tendon is generally overstriding, particularly in someone who has some internal rotation of the foot. So we'll see this with downhill running. We see it with sprinters around a turn, and with jumping, like in the long jump or the triple jump, where you're consciously trying to get as long a stride length as you possibly can. The diagnosis is by tenderness to palpation at that popliteal notch, and also by something called a Garrett test, which I'll show you in just a second on a video. I like to try to confirm this by scanning the lateral aspect of the knee, and as you're scanning for the lateral meniscus and you find the popliteal notch, what you'll see is a halo sign or hypoechoic change all in that little notch, sometimes obscuring the tendon. Next slide, please. So this is the Garrett test. So what he's going to do, he's going to flex it. That shortens your popliteus, and he's going to resist it as you internally rotate the foot, which should bring out pain. So the Garrett test is one of the key tests for trying to determine this. Another test that I like to use, next slide, please. This is the actual only exercises that have been studied to much extent in popliteal tendinopathy. These are called Nylon exercises. But it's also a test to see if you have popliteal problems. So you have the person do a modified sort of running lunge with a long forward step and internal rotation of the foot and see if that creates lateral knee pain. But if they do have what you think is popliteal tendinopathy, then have them do this as an exercise, modify it to where they only have mild, if any, pain. They do it straight in front of them. So you do a set of 30, you do 10 with stepping to your left, so inside your body, stepping straight in front of you, and then stepping to the outside of your body. This Nylon exercise series, so if you did 30 of those and then did 3 sets, focuses on trying to get you used to the position that usually stresses the popliteal tendon. So you need to do it in a pain-free sort of range. So as they get better, their stride length will get longer. The other exercises we give them are some isometric resistance of internal and external rotation of the knee. So that is popliteal tendinopathy. You're not going to see it a lot, but keep it in your mind as a possible cause of lateral overuse knee pain. Next slide, please. Vastus lateralis tendinopathy. Well, you look in the text and you won't see this mentioned very often at all, but just like any of the quadriceps tendons, you can potentially overload and get a tendinopathy in the vastus lateralis. So didn't make this diagnosis, honestly, very often before ultrasound came along, because now we can kind of confirm it with ultrasound. And it's primarily with significant overuse, such as what we see in marathon runners. So you'll get lateral knee pain. It's to the superior portion of the patella and along the lateral border. You'll get pain sometimes with resisted terminal extension and with foot strike during a faster running gait. The diagnosis you can confirm with some lateral hypoechoic swelling and sometimes what I call a stump sign on ultrasound. I'll show you that on the next picture. The treatment's the same as we do with other tendinopathies. You're going to rehab it. This is one you could try. You could try topical nitroglycerin if you chose. You could try some of the other treatments you might like to use for this. But the rehabilitation with cross-training on the bike, quadriceps exercises, and rest from running until you can run relatively pain-free is probably the #1 approach to treating it. Next slide, please. So this is give you an idea of the position of my ultrasound here. This is slightly a oblique long axis scan. So the band just above the joint line is your iliotibial band. What you see toward the, and then you got, I'm sorry, the band way above is starting to see a little bit of the iliotibial band. Just below that is the vastus lateralis tendon. But at the bottom of the vastus lateral tendon, you'll see some hypoechoic swelling and a little stump where it's kind of cut off. So this person has about 10% or so of the tendon that is torn. And sometimes you'll see that exactly right there. So sometimes you'll see this go 50% through the tendon, and then you'll actually see sometimes swelling on both sides of that vastus lateralis tendon. So that's the usefulness of ultrasound in trying to confirm what you're seeing. So if you see a pretty large tear, you're going to go much slower with progressing that than you would with this very small tear. In fact, this patient was able to go back to running within a couple of weeks and just maintain some quadriceps exercise for 6 to 8 weeks while they rehabbed and got back to racing. Next slide, please. So let's move around a little bit more to the posterior knee. And what you would see is the posterior knee is bordered on either side by your hamstring tendons behind the knee. Your biceps femoris laterally coming into your fibular head. And on the medial side, you've got your semimembranosus and tendinosus coming around toward the pes anserin. In the middle, you've got your heads of your gastrocnemiuses. And it's important in this area to think of some anomalies we sometimes see, such as an accessory belly of the gastrocnemius or a significantly displaced kind of or enlarged head of one of the gastrocs. So that's an important finding to look for as well if you're scanning those people with ultrasound, et cetera. So those are important structures, your gastrocs and your biceps when we're talking about posterior knee pain. Next slide, please. So Distal biceps tendinopathy. The biceps tendon is the most common one of the hamstrings to get injured. It's the longest of the hamstring. The hamstring tendons, as you know, cross two joints, so they're at greater risk of injury that. But most hamstring injuries aren't distal. Very few of them are at the fibular head or on the medial side. Most of them are more, we see a lot of high hamstring, we see a lot of mid-belly of the hamstring, but we don't know. In certain sports, it's probably 5 to 10% are distal hamstring injuries that present as pain behind the knee. And the attachment to the fibular head can be a site of both enthesiopathy and occasionally it's a site of avulsion. So I'm going to show you a kind of classic one that was very painful in this area at the fibular head in the next slide. So next slide, please. Well, first, let me show you an example for hamstring testing. This is just a classic. I think all of you know this, but you're going to resist knee flexion in a prone position. You're going to resist it with 3 sort of rotations of foot position so that you're testing different hamstrings as you do that. And then you're going to test it like Dr. Copeland is doing here in about 70 degrees of flexion. And then you're going to lower it down to where you're about 20 degrees of knee flexion. So check it in different positions. See if any of these positions brings out weakness or brings out pain. While you've got them in this position, you're going to look at tenderness palpation at that fibular head, tenderness palpation at either the medial side of the attachment as well. Next slide. So this is the one I wanted to show you. This was pretty painful. This is right over the fibular head. This is a calcific tendinopathy with lots of hypoechoic change. That's your fibular head. You can't really see it very well because it's got so much calcification scattered around it. You can see the biceps tendon coming in long axis to attach to it, but separated somewhat by the hypoechoic swelling. So this is, I think we all wonder sometimes when we see these people who get marked calcific tendinopathies, whether they have a genetic predisposition for that. But these can be very painful, and treatment for those can sometimes, even though you hesitate to inject a weight-bearing tendon, if this is extremely inflamed, this is one that you might inject with corticosteroid or something like that, just to settle down the amount of inflammation and pain that that patient gets. Next slide. But one good thing about hamstring injuries, and this is a protocol that all fellows should know about, are the Askling eccentric protocols, because we really have quite good evidence-based medicine that showed a faster return to play by using this series of exercises. So there are 3 exercises. There's the extender exercise, which you perform twice a day, 3 sets of 12 repetitions. The diver exercise, where you perform daily 3 sets of 6 repetitions. So this is a little more of a slow exercise where you're diving down to touch the ground. And then the glider is a real strength test. So you're doing that every 3rd day with 4 repetitions, steadily increasing your speed as you do it. And I'll show pictures of those so we can talk about how they're actually done. So the extender was aimed mainly at increasing flexibility of the hamstrings. The diver was a combined exercise for strength, but also teaching you to stabilize your trunk and pelvis when you're on a 1-leg stance. The glider was more specific as a strength training exercise to really test the eccentric strength of the hamstring. So as you speed this up, you've got to be careful not to re-injure it. And that's why it's done every 3rd day and only 4 repetitions. Next slide, please. So this is your extender. So in your extender, you're at 90 degrees of hip flexion, 90 degrees of knee flexion, and you're extending the foot up as high as you can get, getting the hamstring extension as much as you can without significant pain. And I tell all my patients, don't push through anything more than very mild pain on any of these rehab exercises that you do. Now, I'll point out the extender that you see there is also where we do an examination technique called the H test, H for hamstring. And basically, you ask your patient to kick that leg up 3 times, and you compare the injured to the uninjured side. Usually, you'll see that they have about a 10 to 20 degree lag in being able to get into full extension on the injured side. I can tell you that the studies that originally looked at the H test said that basically, if you can't get up to 70 degrees on this, that you're not ready to restart running. So you're not ready, you're not far enough in your rehab to go back to running sort of training. I'm a little skeptical of that one because as a long-term distance runner, I don't think I've ever gotten to 70 degrees. Unfortunately, my hamstrings are so tight. But at least you want to compare side to side to be sure that there's not a significant difference. If there's more than a 10-degree difference, don't allow them to start the running phase of the rehabilitation program. So that's the extender. Next slide, please. This is the diver. And the key in the diver is control, trying to keep good balance. But as you lower the hand to the floor in a diving position, that stance leg, you're putting a fair amount of eccentric stress on the hamstring. And most of your patients will tell you right away they feel this. Now, if they can't go to the floor, what I'll have them do is put a paint can or something that they reach down and touch. And then I'll try to get them steadily progress that and lower that as they get better at doing this diver position. But they're, you need to know how your patients are doing their exercise, because patients don't really fail rehabilitation exercises very often if they do them. A lot of times we don't give them the right rehabilitation exercises, but I think if we pick the right ones, most of your patients are going to improve. So this is the diver, and this is also done on a daily basis. And then the next exercise, this is the glider. Now the anterior or left leg in this patient is the injured leg. And so as he slides that right leg back, he's putting an eccentric stress, just like you were in a stretched out running position or a long stride or even a lunge, but you're putting a real stress on your left hamstring with this exercise. And the faster you do it, the more that stress is. So the way they suggest doing it is holding on to something with your left hand if you had a left hamstring injury, putting a sock on your right foot and sliding it back as fast as you can. I find that's a challenging one for a lot of my patients. So I want to see that they can actually do it before I send them out with it. And particularly an older patient, this may not be the best option, and I might have them do just a posterior lunge or something with that. That's a little easier for them to do. But the glider is an effective exercise from the studies that have been done. And as I said, it's the most challenging one and probably is the best test. When that one's pain-free, you probably are ready to go back to fairly hard running. Next slide, please. So I think for these to be effective, you probably do need to supervise them. So I tell people to, maybe you want to see your patient once a week for a couple of times, or have your physical therapist or your athletic trainer see them once a week for a couple of times to see that they're doing the exercises correctly. The glider is difficult to teach. You don't want them to have any pain during performance. You do the Askling H test that I talked about to see how that hamstring is coming. If you're getting really good extension on that H test, you're probably ready to begin slow running most of the time. But as you go beyond this and get into dynamic drills, which may include hopping, overstriding, bounding, other things, you need to make sure they're able to do this basic Askling series well first, and then you can move on to those. There's a reference I left there of the Aspetar protocol on hamstring recovery. It's an extensive series of hamstring exercises that you can try to progress your patients with, and really an excellent series that they've studied there with elite soccer players. So that's a good reference for you to know. Next slide. So here is the evidence, and this evidence is truly outstanding for the Askling exercise. If you look at elite or sub-elite football athletes, football meaning soccer here, their return to play was 28 days with the Askling protocol versus 51 days with the standard concentric protocol. In elite sprinters and jumpers, it was 49 versus 86. For high hamstring, which is always difficult to treat, it was 73 days versus 116 days. And there were very few re-injuries in either group that was on either concentric or eccentric exercise protocols. So the Askling exercises, good EBM, several studies that document this. Next slide, please. So, but what about if you had some upper calf pain at the posterior knee? Well, if it's on the medial side, one of the conditions you need to know about is what we call semimembranosus gastrocnemius bursitis. It's a localized swelling and mild tenderness. Sometimes you'll have an associated Baker's cyst, but a lot of times you're seeing more extensive swelling and more diffuse swelling than you see with the classic Baker's cyst. If it's a lateral proximal calf, again, we think of the popliteal tendon, and we talked about that. But we also think of, in either the medial or the lateral side, could it be a gastrocnemius insertion, an avulsion, or some sort of injury to that tendon? so that you have a partial tear or just inflammation. So, and that one is going to have pain exacerbated by if you're having them do a heel raise on a step, like in the Alfredson exercises. If you're having them do a heel raise on a step, the down motion, dropping the heel below the step, is going to create pain. Next slide, please. So this is the case. This is a 61-year-old male with right posterior knee pain. He's an avid cyclist, and he's had this worsening pain for 2 to 3 months. About 6 weeks before he started the pain, he had had an insertional hamstring tendonitis. He'd used a compression sleeve. He'd done hamstring exercise, and it helped, but it didn't really get rid of the posterior knee pain. His hamstring tightness went away. His hamstring soreness went away, but the posterior knee pain did not. So it was severe if he tried running uphill or sprinting. It was only moderate with biking and really none at rest. Next slide. So it was unremarkable on inspection. He didn't have a knee effusion. He had normal range of motion in negative special tests. Just some tenderness to palpation over the posterior lateral corner, and specifically near the overlap insertional areas of the hamstring and gastrocnemius insertions. He had minimal pain with hamstring testing, but he had pain on a one-leg heel raise in the down portion of that heel raise on a step. Next slide. So I thought this might be his gastroc. So this is an unusual finding on ultrasound. What you see is this is the gastroc coming up to attach to the posterior condyle. And you see this significant calcification that I've got the arrow trying to point to, that's right at the musculotendinous junction. And that's right where his tenderness was. This was also associated with a lot of increased Doppler flow, so it was the area of inflammation. I don't know what this represents. I know it's a calcification and it's abnormal, but I didn't see a lot of tear in either the tendon or the muscle. But the calcification indicates there probably had been a tear there or some sort of injury that led to the calcification. I don't think it's an avulsion, and I don't think it's a fibella, because a fibella would probably be more distal in the tendon itself. So this was definitely the area of injury. And it's just another good example how an ultrasound could help us make this diagnosis if we're looking for either a tendinopathy or some sort of injury like this, where you had some calcification and abnormal injury to the gastroc insertion. Next slide, please. So on the opposite side, this is a patient who had medial posterior knee and upper calf pain. And this is a classic sort of example of semimembranosus gastrocnemius bursitis. And so the semimembranosus is superficial and it rotates a little bit medially to attach near the pes answering. So it's the top muscle you see up there. And you see right at the very top, there's a tiny little bit of hypoechoic area that's over the tendon as it's just right at the top. That's the area, yes. Now below that semimembranosus and between the gastroc coming up, you see a large bubble of fluid, hypoechoic change. And this is where the intersection of the gastroc coming up to attach to that posterior part of the femur, the femoral condyle, and your hamstring crossing over to attach lower down. This is where they cross and is a potential space to develop swelling. Next slide, please. This is what's called the U sign. I'm sorry I cut off the left side of the screen, but that proximal area is sliding down about 2 to 3 centimeters below the attachment of the gastroc. That's gastroc muscle proximally, surrounded by fluid on both sides, forming what we call a U or U sign. So this is your gastrocnemius semimembranosus bursitis. This is a pretty swollen one. That one was very large, but you'll see a lot of them that are smaller. And sometimes you have the U sign, you don't always, but a lot of times you'll have fluid on both sides of this, which differentiates it from what we usually see with the Baker cyst. And the Baker cyst will be a little more medial. So next slide, please. This is an 11-year-old girl who was sent over to me by the orthopedist. He said, she's got a knot behind her knee. I think she's got a Baker cyst. And sure enough, that's your perfect Baker cyst. Beautiful sort of contour that's shaped. Now, but Baker cysts can be septated. There are a lot of changes. And as you know, ultrasound is very effective. If you do get these that are really painful, you can do a 4-quadrant fenestration and drain them, or other ways to get rid of them. But this is your classic sort of Baker cyst. Usually it's a little more medial than what you're going to see with the semimembranosus gastrocnemius bursitis, although you can have both in the same patient. So this patient actually had no mechanical issues. She was 11 years old. They didn't want to do an MRI on her because of expense, and she was having no symptoms. So we just watched this and followed it for years and really never gave her any problem at all. So next slide. So last condition to talk about a little bit, popliteal artery entrapment. And this presents as mid-posterior knee and sometimes upper calf pain. And it's often triggered by an anomalous position of the gastroc. So the gastroc is a little too close to the vasculature, or even an accessory belly of the proximal gastroc. So there is that anomaly where you will have actually 3 proximal gastroc sort of bellies at the proximal area. We see it mostly in young men in cycling. I've seen more in cycling than any other sort of sport, but you also see it in military training and in runners. There's pain in the posterior knee a lot of times and in the upper calf, and kind of a pseudo claudication because it starts hurting with exercise and stop and it goes away. And ones that have gone to surgery have generally shown pathological thickening of the popliteal artery from a repeated compression. Next slide, please. So this is a classic sort of finding on distal or digital angiography. And what you're seeing is the right knee is on my left side as I look at the screen, and it's got a long sort of carved out narrowed area. You can see that it's got proximal dilatation, narrowing, and then distally it doesn't show enough to know whether you've got dilatation. But if you go to your left knee, it's completely occluded. So this is bilateral popliteal artery entrapment. Most of the time you get it on one side more than the other. A lot of times it's just on one side. The way you try to diagnose it on physical exam is you palpate the distal pulses, particularly the posterior tib. You try to get an idea whether you might have, if you have symptoms on one side, do you have a diminished flow or diminished pulse? Then you have them do dynamic plantar and dorsiflexion of the ankle while you're monitoring the pulse. I'll put them on a step and have them go up and down with that ankle, dorsiflexing it, plantar flexing it, and seeing if I can detect any change in the pulse. Honestly, this is very challenging to do clinically to make this diagnosis. I think it's a very difficult one. I've tried dynamic Doppler ultrasound on patients that I thought had this. That's also challenging because sometimes you'll see diminished flow, but trying to keep that ultrasound position while you're having someone do dynamic exercise can be a real challenge as you're doing it. So, but if you do see it, if you see it really occluded or the flow stops on your ultrasound, that's a very good diagnostic test. But I would say most of these patients, certainly before we think of considering anything with surgery, are probably going to wind up with angiography unless you've seen quite a few of these on ultrasound and are very confident. So next slide, please. So let's summarize then what I've tried to go over for lateral and posterior knee pain. Well, I think it's important for you as fellows to know the common diagnoses, the common conditions that are going to cause lateral and posterior knee pain. The most common of these is the iliotibial band and probably hamstring injury. Those are both such common injuries in sports. You're going to see a lot of them during this year of your fellowship. And knowing some of the approaches to treating those and where the evidence is, because there's good evidence for both ITB and hamstring, is very valuable to you. Less commonly, you're going to see this popliteal artery entrapment, and it's going to be challenging to diagnose if you do see it. Semimembranosus gastrocnemius bursitis is not rare. It's not nearly as common as some of these other conditions, but you're probably going to see that if you consistently apply your ultrasound probe to people who come in with pain in that area. Popliteal tendinopathy is rarer than the bursitis, but you may see that occasionally as well. And then proximal gastroc tendinopathy is somewhat rare as well. But usually you can think about a mechanism. If they give you a mechanism of extensive calf stretch before the injury started in some fashion, sometimes it can be dynamic. I've seen it in yoga before, for example. That may point you toward scanning that area and trying to see if you can make that diagnosis. ITB syndrome is common, and evidence-based medicine supports that abduction strengthening is the key to treatment. It's been the most effective treatment we've found in the literature to date. Hamstring injury less frequently causes lateral, medial, and posterior knee pain, but strong evidence-based medicine supports that ascling exercises are the best treatment we've found to more quickly return these patients to activity. And I think it probably applies, although the studies weren't done strictly on distal hamstring, I think it applies to the distal hamstring as well. Popliteal artery entrapment is difficult to diagnose, but you got to consider it in posterior knee, upper calf pain, and overuse activities if you just can't come up with another cause that you can ascribe that type of pain to, or particularly if you see a really abnormal looking gastroc, and it seems to be very close to the vasculature in the posterior knee if you're scanning that area. So that's my overview of lateral and posterior knee pain. And I can stop right there because I know we got started a little late. I did put a few questions that you could use for board review if you want them.
Thank you so much. I'm going to stop sharing and take a look to see if anyone has any questions for us. And for those who may have been shy to add questions during the lecture, please feel free to send them now. One of the questions was with regard to IT band injections. How would you approach that? What would the approach be, and should you be concerned about tendon rupture with this type of injections? And then I'll follow, there's several parts of the question, but I'll follow up with those. But would you mind talking about the approach for IT band injections?
Well, I allow the patient laterally. I try to palpate the ITB because you can, and a lot of patients are able to palpate that as it comes across Gertie's tubercle. I'd like to do the injection right under the ITB at Gertie's tubercle because that's usually where I see the swelling. But since I've started using ultrasound all the time, I mean, I practically scan all my patients practically. When I get down to the ITB, I'm looking for an area that to me looks abnormal. Is it swollen or something? And then you can easily guide it in there. This is a very easy injection that any of you guys can do with just a little bit of practice. And, you know, use your typical techniques, give them a little ethyl chloride spray or something to numb it up and go in there. Are you going to rupture the ITB? I think you'd have trouble rupturing it with a saw. I mean, it just doesn't rupture very easily. Even when they go in at surgery, it's tough to take down from there. So I wouldn't worry too much about steroid around the ITB.
And then the other question, which was a question similar to what I had, was if you're looking at calcific tendonitis or tendinopathy, whether it be for the gastrocnemius or the biceps femoris, do you do tenotomy, like percutaneous tenotomy, like they do in the shoulder, or what type of approach might you be using for that?
Well, you know, the most effective thing, the most common calcific tendinopathy is supraspinatus. Okay. And probably all of you are going to see that this year if you haven't seen it already. And it's often painful, but sometimes you'll see a lot of calcific change and it's not that painful. But what we tend to do in the shoulder is barbotage. We'll take ultrasound from two directions and try to really lavage it and see if any of the calcium is soft enough to suck out. After that, I mean, all bets are off as what's going to work. I mean, you can literally, we've got a bunch of patients with calcific tendinopathy of the quadriceps tendon. That's another very challenging one. You know, big calcific lesions we've sent to surgery to take out. You don't want to take out too much because you'll weaken the tendon and maybe get a rupture or other things. Can you do some sort of percutaneous tenotomy or other things? Well, I will try going in. This is a situation where I will numb them up really well, and under ultrasound, I'll go in and needle the hell out of a bunch of these little calcium deposits and see if I can break them up and make them less painful. But there's a lot of research looking into, is there a genetic component to the people who get calcific tendinopathies, and would anything work better? And we haven't found that. I think this shockwave lithotripsy has shown some promise in a few small studies, not enough to reach the EBM levels that we would like, but it definitely shows some promise. And when I've traveled in Europe and overseas, they really like it in several countries that I've been to. So I think that may be another thing that's worth trying if you see calcific tendinopathies. Certainly before you do a lot of surgery or a lot of, you know, some of the stuff I've done, I'm just not sure if it makes much sense, because when you try to needle the quadriceps tendon, these big calcifications, it's tough to accomplish much with that. But, you know, when you do try things with your patients, I haven't seen any of the other things that have made a tremendous difference in it, honestly.
Another question was, for patients who present with a painful Baker's cyst, would you consider draining the cyst, or do you recommend another modality?
I like to drain them. And, I've drained quite a few of these each year. And there was a good paper, I don't remember, it's in the ultrasound literature somewhere, but what they talked about was doing a 4-quadrant sort of aspiration of the cyst, because a lot of them will have, a lot of times on ultrasound, you can actually see a septation in them, or you can see that they're multi-septated. So if you have that, you've got to get into the different parts, because you'll think, hey, I drained some really good fluid out of this, and you look and gosh, you still got a big cyst there. So that's pretty disappointing when you're sitting there with a needle and you know you got fluid and you still got almost as much cyst. So look carefully, because a lot of times you're seeing a complex cyst. And this 4-quadrant approach that they talked about is basically you go in, and they're very easy to see on ultrasound. So you numb up 4 little wheels around the cyst, take an 18-gauge needle and just go into each quadrant. And the idea with that is then you get them to really put some compression on that cyst and keep kind of self-massaging over that compression, because you want to drain every bit of that stuff you can get out of there and hope that it won't close back up and just reform. Since Baker's cysts actually connect to the joint, they have a great tendency to recur. So I don't care what you do, they like to come back. So I like to make a pretty big series of holes in them so they'll stay away for 6 months to a year or something longer. But I'm probably going to get to do the same thing to that patient next year, is my experience at least.
And you mentioned the Askling exercises for hamstring tendinopathy. What are your thoughts on those as compared to the Nordic hamstring curl exercises?
Well, one, if you want to see a ridiculous picture, look at the hamstring topic and Up to Date, and you'll see me trying to attempt a Nordic hamstring. Now, for most of us, we're going to die if we do more than about 2 Nordic hamstrings. It's harder than hell. And then you can see these elite soccer players, you can pop down and do 15 of them just as fast as you can go. It's a very tough exercise. So it's a minority of our patients, and usually very good athletes, who can do Nordic hamstring. But remember, the Nordic hamstrings were studied for prevention. They're probably the best prevention we have for hamstring injury. So I really encourage them in my athletes who are capable of doing Nordic hamstrings. Ohio State, a few other universities built this equipment that allows you to do a protected Nordic hamstring on, it's a kind of machine that allows you, it controls you, so if you fall too far forward, it'll catch you. So I think, so some universities have really good setups for helping you rehab that. So maybe some of your training rooms will have that. But I would really encourage using it for prevention, for teams that are prone to it. Soccer is the classic one, but also probably for runners and others. So, but does it work as well for treatment? It's going to be the last phase of treatment, because it's one of the toughest things you do. So if you're going to rehab them, you're going to have to take them through a lot of rehab that's easier than that before you add in Nordic hamstrings. When I have someone who's trying to get back to, 110% effort, like a lot of your elite athletes, that's phase 3 for me in the rehab I give them. I start them off with the Askling exercise. When they're doing really well, I give them a lot of dynamic drills, which include hops. The hop, and one way to tell if the injured hamstring is catching up to the regular hamstring, if you have them hop 10 times on their right leg, see how far they can go, then have them hop 10 times on their left leg, see how far they can go. So it's dynamic exercise when they're able to do it is a great way to assess how they're coming. Can they do certain drills, etc. So I think you take them to a dynamic phase, and then you go to an over-strengthening phase, and that's where heavier weights and Nordic hamstring exercises come into play.
Yeah, that's very helpful. Thank you. I know we're running short on time. I just wanted to ask one more question, because I know it's often CAQ pertinent. You mentioned ITB syndrome and being more common in runners, but the second most common population is cyclists. I was wondering if you could talk about maybe some changes that we would have in the bicycle fit for someone who, whether has newly started up cycling or is an avid cycler, has developed ITB syndrome.
Yeah, so usually in your cyclists, they can make one of 2 mistakes. Either they can have the seat height too low, so they're getting way too much knee flexion in their cycle stroke, or they can have the seat height actually too high to where they're getting a full extension, and it's a challenging sort of position for them to put full force when they get to bigger degrees, which probably really, that's like the elite runners who land with the leg extended and are getting a lot of pressure at that, particularly on downhills. So when you have the cycle to where you're really stretching out to be able to reach that distal position, that really tightens the iliotibial band, compresses those soft tissues. That's where you start seeing, in the cyclists that I've seen with that, a lot of them will have either a true bursa or a pseudo bursa right under that distal ITB. So either one of those two positions on cycle. I'm not an expert on how to fit the cycle, but I really try to get my patients to work at a good cycling shop we have here, where they will do a really good job of looking at their fit and seeing if they're having a problem, particularly if they're getting ITB and they're a pretty serious cyclist.
Great. Well, I think those were all of the questions that we have. So thank you so much for giving us this outstanding lecture. I think often an left out part of knee education for sports medicine. So extremely helpful tidbits and pertinent facts for the CAQ exam. So thank you for that, Dr. Fields, and thanks for everyone for bearing with us as we had technical difficulties near the beginning. But just if everyone is able to, we'll get a post-lecture. Andy, I don't know if we're still sending out a post-lecture survey, but that'll pop up in the chat. But if anyone else has questions, please reach out to us.
Well, thank you for having me, and I apologize for the technical difficulties, but you know, they didn't have computers when I started. so I was counting on you young people to get my computer working.
I have no excuse for what happened on my end. I can't explain it, but.
All right, have a great night, everyone.
See ya.